My name is Derek Griffith. I'm the new chair of Global Action on Men's Health, and it's a pleasure to be here with you today and to host this webinar on men in general practice, barriers and bridges. Next slide. So if you don't mind, mute your phones, mute your computers and so forth, and feel free to use the sign-in using the chat and your name and organization, just so we know who's here. And then for Q&A for questions and so forth, please use the Q&A function on the Zoom platform for that part. And please do join in and add any comments and questions and thoughts you may have throughout the time. We are trying a new format, a shorter format. And so while this webinar is going to be recorded and posted on the website, we do want to, we are piloting a new format to basically see if a shorter format will make it easier for folks to attend. And so any feedback on that too would also be appreciated. Next slide. So again, I'm in addition to just introducing this group, also let me say thank you to Peter Baker, who's the Executive Director of Global Action on Men's Health, who's helped to organize this event. So we'll begin with the presentation by Ruth Mursa, who led the paper, Men's Health Seeking and Engagement with General Practice and Integrative Review. And so her work in the Journal of Advanced Nursing Practice in 2022 is the main sort of focus of this work. And then we'll have brief responses by Gary Wittert and Margarita Bernales, and then discussion and thoughts, particularly around policy and practice as it relates to these issues. Next slide. So one of the reasons that we're doing this webinar is, again, this is a common issue and problem of trying to get men into general practice, preventive care, and how do we think about that? And it's usually that men are described as suboptimal users of general practice and primary care services. And while it used to be that men were seen as the standard and women were actually seen as overutilizing services initially, this has become something that we're now focused on in the men's health community, because it's recognized that men are actually the ones who are underutilizing services, not that women are overutilizing them. And that one of the comments from men's side is that they often say that it's not easy to access and utilize, and because of limited operating hours and so forth. And yet this is, even though this is a common issue and there are a common set of problems and barriers and so forth, we don't really know how to overcome them and to solve them. We haven't sort of, and regardless of the country that these issues are taking place in, this seems to be a rather universal problem. And so this is why, particularly from a global action on men's health standpoint, this is an important conversation to have. And so this webinar is really an important opportunity to understand better understand the key issues and begin to explore next steps of research, policy, and practice. Next slide. So just by way of introduction, Ruth Mursa. Ruth is a registered nurse and an endorsed nurse practitioner, highly experienced in the field, and holds a MN degree in both advanced practice and MN in nursing as a nurse practitioner, as well as postgraduate qualifications in sexual and reproductive health and continence. So PhD candidate at the University of Wollongong, and researching men's health seeking and engagement with general practice. And again, we talked about the paper already that she led, and that's going to be the major focus of her presentation today. Next slide. And so again, we'll have the brief responses from, next slide, there you go. Professor Gary Wittert, Director of the Freemason Center for Male Health and Wellbeing in the South Australia region, South Australia Division, excuse me, Chair of Medicine and Senior Endocrinologist at the University of Adelaide and the South Australia Health and Medical Research Institute. And Dr. Margarita Bernales received her PhD in Community Health from University of Auckland, New Zealand, and and also has a master's degree in health psychology from Pontifical University. I'm not even going to try to do this, in Chile. So I'll let you when you introduce yourself, you can say that. I'm not going to try to butcher the fourth thing. Thank you. And is currently an assistant professor at the School of Nursing at the institution where she is a professor now in Chile. So if we can, next slide, I think that's it.
I think the next slide is Ruth. So Ruth can now share her presentation. Can I just say, Derek, we had a problem with the chat at the start, but it's now been fixed. So if people can now go to the chat and sign in, that will be really helpful. Thank you.
Yes. Ruth, over to you.
Well, good morning, everyone. Can you all hear me? You all good? My name is Ruth Mursa. Thank you for this lovely invitation to present this morning from Australia, but I'm also mindful that it's midday in the American region, and it's also in the evening in the UK and Europe. So good evening, good afternoon, and good morning in Australia. So thank you, like I said, for this opportunity to speak today. So Ruth Mursa, I've been a registered nurse and a nurse practitioner, a registered nurse for over 34 years and a registered and a nurse practitioner for about 11 years, working in general practice and also non-for-profit organisations such as family planning and Marie Stopes, so non-for-profit organisations. Through my years working in primary care and also reproduction and sexual health in clinics, I've had a really keen interest in the area of men's health. I guess it's from dealing with women, but also when they come in with their partners and when just actually seeing the dilemmas that men face in our healthcare system. So it's really brought that keen interest into what I'm doing now. So the objectives of the presentation are, so why research this topic, the findings of the literature review that we did, the structure of the research and how we will address the research aims, and the provisional findings of the survey. Before I go on, I'd just like to acknowledge my supervisors, my primary supervisor, which is Professor Elizabeth Halcombe from the University of Wollongong, Dr. Chris Patterson and Dr. Gemma McCurley. Thank you. So what do we know about men's health? Well, it's a sad story, isn't it, that globally life expectancy for men is around 5 years less than it is for women. And 1 in 2 Australian males have at least one chronic condition. The current figures indicate that 75% of males in Australia are affected by being overweight and obese. And we know that being overweight is a risk factor for many conditions, including cardiovascular disease, hypertension, diabetes, sleep apnea, and osteoarthritis. We know that males are more likely to smoke, consume fewer fruits and vegetables, drink too much alcohol, and be less physically active than females. And men experience poorer health conditions as opposed to women across a variety of areas, including worse cases of mental health, increasing rates of suicide, diabetes mellitus, heart disease, and also some cancers. And general practice is the front line, the first point of contact for the healthcare system for the majority of people. In Australia, just mindful of the fact that you won't not know that in Australia, it's often run by, it's a small business and it's often run by them GPs themselves or corporate organisations. It's funded by Medicare, which is a government funded payment system, but it's often also expected that patients will have a co-payment, so they'll have to contribute to that, the cost of actually going to see the GP in the practice. And contemporary general practices are staffed with multidisciplinary health professionals, including doctors and nurses, but also many practice collaborating with either co-located or local allied health professionals, including physios and psychologists, dietitians, speech pathologists, and pharmacists. So we undertook a literature review, and this was published in the Journal of Advanced Nursing in 2022. And the aim of the paper was to critically synthesize the literature that described men's help seeking and engagement with general practice. We had 20 studies that met the inclusion criteria. And the literature identified 4 key themes, structural to 4 key themes as to the barriers that men face. Structural barriers, the internal barriers, men's understanding of the role of general practice, and self-care and help seeking. So the structural themes working around for working men and health professionals identified that the poor availability of appointments outside of the working time made access to general practice challenging. The waiting times to get an appointment was problematic, and there was also privacy concerns, particularly around booking an appointment and having to potentially share either the perception of needing to do it or the fear of the reason to share the appointment, the reason for the appointment with the reception staff. Men in general practice with the literature review also noted that the feel of the general practice was a space that was geared to females, a female orientated space, with the focus of general practice, in their opinion, focusing around the needs of women and children and not for men. And these barriers left men feeling unwelcome and alienated by a service that was perceived to be inconvenient and insufficient to their needs. For internal barriers, there was issues related to fear and embarrassment, hegemonic masculinity and stoicism. The need to seek health services was perceived by some as a sign of weakness and vulnerability. And it's important to note and highly significant that the challenges of this in relation to mental health concerns as non-disclosure and self-sufficiency was actually viewed as a strength. So theme 3 identified men's understanding of general practice. And what is general practice to them? Well, general practice for them, according to the literature review, was a place for acute care, for treatment, unaware of the fact that general practice is a place of health education, health promotion. The literature told us that men attended less than women, we know that, and the literature identified that GPs described how working men infrequently presented for health screening, but yet as men get older, their health checks and screening was actually shown to increase, which was a positive. The 4th theme identified self-care and help seeking. Men often ignored issues and presented later on in a health trajectory. The literature told us that the relationship with the GP was really, really important. There was a real degree of trust there. And the triggers for help seeking in men were often acute issues related to acute pain or a condition when it got to such a stage that they were unable to go to work. And this is what drove them to actually go to see the GP. The literature review has elucidated barriers that men can face in help seeking and engagement with general practice, in that men can find general practice unwelcoming. Psychological barriers that impact engagement and help seeking were identified. And the findings demonstrated that men largely view general practice as a place for acute healthcare and don't appreciate its role in preventative healthcare and advice. So the review findings identified a gap in the knowledge in relation to the impact of gender and the effect of the utilisation of general practice to its full capacity. And these findings, together with many years of clinical practice, was the motivation to undertake a PhD to explore men's help-seeking engagement in general practice. The aims of the project are to develop a greater understanding of how adult Australian males engage with general practice for preventive care. The aim will be achieved by addressing 2 key questions, and they are: what is the relationship between men's health literacy, lifestyle risk and engagement in preventive care? And what are men's experiences of engaging with general practice for preventive care? The chosen methodology is a mixed methods, and the combination of the quantitative and qualitative data collection will allow a deeper insight into the research problem than would be possible with either method in isolation. The complex and multifactorial nature of the study's aims demand an exploration from multiple perspectives and flexibility in the selection of methods to meet the aims of the project. And using both methods to answer this overarching aim will allow for a more complete understanding of the research problem, increasing the richness and scope of the findings. The mixed methods gives a voice to the study participants and ensure that the study findings are grounding in the participants' personal experiences. So our study setting, we were very fortunate to secure the support of the New South Wales Rural Fire Service. And the New South Wales Rural Fire Service is the largest volunteer-based firefighting service in the world. The New South Wales Rural Fire Service was chosen as a setting for the project due to its high number of men either volunteering or working within the service. With varying educational levels, demographic characteristics, and the geographical distribution across metropolitan, regional, rural areas of Australia, of New South Wales. Men from all walks of life who are represented by their local communities. So New South Wales is the largest Australian state by population, with 8.5 million people calling it home, and it's located on the east coast of Australia with an area of approximately 809,000 kilometres. It borders to the north with Queensland, it borders to the south with Victoria, and it borders to the far west with South Australia. And it also encompasses, the area encompasses the Australian Capital Territory, which is home to Canberra, Australia's capital. So the first, we wanted to conduct a cross-sectional online survey, and it was used to understand how men locate and use health information with their current status. The current status with lifestyle risk factor and how they manage their health and engage with healthcare providers. It's divided into 3 sections, demographic questions, health status, and health literacy questionnaire. The health literacy questionnaire is a validated tool to measure health literacy, assessing people's ability to understand, access, and use health information. The survey was delivered via RedCap, and the survey was then imported into SPSS for data analysis. The health literacy questionnaire domains are designed to measure the experiences of people who have, when they engage in understanding, accessing, and using health information and health services. The domains are feeling understood and supported by healthcare providers, having sufficient information to manage health, actively managing health, the social support for health, appraisal of the health information, the ability to actively engage in healthcare with healthcare providers, navigating the healthcare system, the ability to find good health information and understand health information well enough to know what to do with it. So our survey, participants was open for 2 months. It was last year. It was open from October 2022 to December 2022. And it was open to anyone identified as male, 18 and over, and either employed and or volunteer for the New South Wales Rural Fire Service. Preliminary survey findings, 505 men completed the survey, and 74 surveys were removed due to incomplete data and duplicates, and therefore we were left with 431 surveys which were included in the analysis. So some of the key points. 85, the mean age of our participants was 52.67, and the range was from 18 years to 90 years, a pretty impressive range, I thought. 87.7% of respondents were born in Australia, and 1.6 respondents were Indigenous Australians, and 7.2 identified with an ethnic origin other than Australian. 52.9 respondents were from rural areas, and 75.9 were rural fire service volunteers. We found that 85.6 participants were actually in a relationship, and the highest education completed for high school, for leaving at high school, was 20.7% of respondents. 35.7% had a university education, and 65.9 had a mid-range household income of between 45 and 180,000 Australian dollars. 71.7 held private health insurance. The BMI was calculated from height and weight provided by the men. The mean was 29.8, and which is the highest end of the overweight category, just about to jump into the obese category. 41.5% were overweight, 36.5% were obese, and just 18.6% of the guys that we asked were actually in the healthy range. That means that a staggering 77.9% of males surveyed are classified as being overweight or obese in that category. We looked at the guidelines to assess smoking, nutrition, alcohol, and physical activity, commonly known as the SNAP. Just 8.4, this was quite reassuring, 8.4% of our participants were tobacco smokers, which was far less than I actually anticipated, and 64.7% had never smoked, with a positive improvement of 26.9% who'd actually quit smoking. Current guidelines for Australia with fruit and vegetable intake is 5 serves of vegetables and 2 serves of fruit. And just 11.1% of participants ate the recommended serves of vegetables a day, and 52.7% ate the recommended fruit intake a day. Current Australian guidelines suggest that no more than 10 standard drinks per week and no more than 4 standard drinks in one day should be consumed. Our statistics showed us that 21.8% of the men had 6 or more drinks in one session, at least monthly or more. Physical activity, the guidelines in Australia are broken into guidelines that represent 18 to 64-year-olds and 65-year-olds up. So the physical activity for the 64-year-old and under, we asked about exercise, about how many hours they were inactive, how many hours a week they had moderate physical activity, how many hours they had vigorous physical activity, and how many days a week they had muscle strengthening exercises. The guidelines suggest 2 is the minimum. 75% of the men surveyed, the 64-year-old and under, do at least 2.5 hours of moderate physical activity, but 46% of men 64 years and under spend at least 8 hours a day being inactive. The flip side of that, and I suggest it's related to retirement, is just 15% of men 65 and over spent more than 8 hours. So just 15% of those men actually spent less than 8 hours. That's more than 8 hours a week being physically inactive. Participants were asked to describe their overall health using a self-rated score formulated in general as how would you rate your health today, with the possible choices being excellent, very good, good, fair, and poor. And 42.9% of men reported good overall health, which is really kind of reassuring. We wanted to know how many times participants had been diagnosed with any of the following health conditions, and then free text the conditions not listed. The listed health conditions and their associated results are above. So 32.9% reported hypertension, 26.2% of respondents reported a mental health condition, and 29.9% of men had a diagnosis of being classified as overweight or obese. Interestingly, as I said before, figures indicating that 77.9% of the men surveyed were actually classified as being overweight or obese. We asked participants about if they had a regular GP or a GP practice, and 79.8% said yes. We asked how many participants would have an appointment at the general practice, and the results here indicate that the participants are being seen in general practice, with 185 men, which is 42.9%, attending 2 to 4 times a year, and 98 men, so 22.7%, attending at least once a year. We asked men to indicate when some of these blood tests, not just blood tests, have been undertaken in the last 2 years. So blood pressure, cholesterol, fasting blood sugar level, dental check, skin check, and a healthy heart check. Some healthy figures here in relation to blood pressure and cholesterol checks. However, skin checks were reported at 54%. When we know that at least 2 in 3 Australians will be diagnosed with skin cancer before the age of 70, and the risk for men is actually quite high, it's around 78%. The final section of this survey is the health literacy questionnaire. There are 9 scales in total, the top 5 and the lower ones, the lower 4. The first 5 scales are answered using a 4-point Likert type response. The lowest scale was seen for 5, which is appraisal of the health system, with an overall mean score of 2.8 and a standard deviation of 0.52. A low score indicating participants cannot understand most health information and get confused when there's conflicting information. The highest score was seen for 1, which is feeling understood and supported by health professionals, with an overall mean score of 3.08. A high score indicates an established relationship with at least one healthcare provider that they know and trust. Scales 6 to 9 are a 5-point response. The lowest score was 7, navigating the healthcare system, with a mean score of 3.7. A lower score indicates unable to advocate for themselves or find some help to someone to help them with limiting understanding of healthcare resources, what healthcare resources are available. The highest score is number 9, reading and understanding health information. And this indicates an understanding of written information and also the ability to fill in forms. So please be aware that the quant analysis is not complete. We've still got some analysis to do with the health literacy questionnaire in relation to the demographic characteristics that we also completed. We're looking at things to do with the health literacy questionnaire in relation to the participant's age, the health literacy questionnaire compared to their income, their education level, and also being from a rural or remote place of residence. The next stage of our study is actually the qualitative phase. So we've got the rest of the quant study to analyse, and then we're going to move on to the qualitative stage. The qualitative stage is going to be interviews to explore how men engage with general practice as a source of preventive healthcare. And these questions will extend on to further explore the survey data, and some aspects of this phase will be determined once the survey data, like I said, is completely analysed. So I'd like to add on conclusion that we're very grateful for the response rate of the online survey. And I'd also like to add that we received multiple emails from men thanking us for undertaking this study. And their comments were that it was actually greatly needed, and they were really grateful that we'd actually taken this study on board. And we also had multiple, I can't tell you how many people actually were keen to be interviewed. We've not got to that stage of interviewing, but we're going to start narrowing the numbers down. But keen response rate to be interviewed. It sounds like the men, the voices of the men, they want to be heard. And we look forward to the qual interviews and hearing the voices of the men regarding this important topic. So exploring men's help seeking and engagement with general practice is an important foundation to understand the current issues and form effective planning of general practice services that meet the needs of men and optimize their health outcomes. So just to finish, a few ideas, not based on any research findings per se, but just the knowledge of what's going on in our world in relation to men's health, and some ideas for future research, policy and practice. Future policy and practice. So as an organisation or as a general practice, is general practice do we promote what we offer? Do we need to increase our visibility and change the narrative of general practice? Because it seems like men don't understand what we're actually able to provide for them. And it sounds like there's some significant marketing that needs to go on there. Does a one-size-fits-all healthcare approach or program meet the specific needs of our diverse communities? We need to look at care through the lifespan, targeted and financially supported campaigns to get males into general practice, to consider things through the lifespan. I often think about things like preconception care. You know, we often men present later at, you know, from 45, 50 when things are starting to go wrong, but we need to be targeting them when they're younger to address health issues. And I think about preconception care. When you think about preconception care for women, it's all about things to do before you get pregnant. We should be doing that more. I know there's a campaign to move that along, to look after men, to increase health birth outcomes for babies, but also to look after men to do with the significant impact of a new child coming on, for example, and mental health issues, all of those things. And I guess heightening the multidisciplinary approach of the primary healthcare team, delivering through funding and support and ensuring that the most suitably qualified and educated healthcare professional delivers the message and supports the individual. Thank you.
Thank you, Ruth. Okay, we've got so let me quickly go to Dr. Wittert and then Dr. Bernales. So you're muted, Dr. Wittert.
Thank you very much, Derek. Ruth, thank you for your talk and your enthusiasm and for undertaking such important work. Some perspectives based on 25, nearly 30 years of work in this area. There's two dimensions to this. One is the public health and the other is service provision. We find that most men want to go to their general practice and to receive services from a healthcare practitioner that they know. And after the GP, the second most important comes to be the pharmacist, which is relevant to a lot of debate taking place in Australia at the moment. Both in terms of public health and service provision, you highlight the problem of health literacy being a barrier to effective uptake of care. And there are lots of reasons for that, which I won't go into. The second major point you raise, which is access, relates to a number of factors which you've highlighted, but one of them is the tendency of men to self-monitor. And that probably explains the discrepancy between the age-related number of attendances. When men know that they have a condition, they're far more likely to go on a regular basis. Whereas if they don't know what the problem is, then they're more likely to self-monitor, and this plays into the issue of the health literacy. So the issue of ambivalence around seeking care versus health literacy is something that I think is worth teasing out. You've highlighted the feminist environment, and I think that's really important, but also the orientation and pattern of communication by general practice practitioners matters. Men will not ask questions because they don't want to impose, they don't communicate in the same way that women communicate. So unless they're asked about problems, they won't volunteer the problems, and therefore opportunities about preventative health are lost. And that's compounded by the problem of health literacy. The issue of masculinity, I think, is moot, and I think should be largely, apologies for the dog, the issue of masculinity is moot and should be dropped really from the discourse because it appears to make no difference to the use of health services by men. And on that subject, we find consistently that whether it's for mental health conditions or physical conditions, men use health services with the same frequency as women once you discount reproductive services. The problem seems to be more what takes place in the course of that service, rather than whether they wish to access or whether they access in a timely manner. And in particular, when it comes to mental health services, we recently published a paper showing that men who have a high burden of mental health symptoms access healthcare practitioners far more frequently than those men who do not have a high burden of mental health symptoms, but only about 40 to 50% of those with a high burden of symptoms get referred on. Now, 10 to men reported very similar findings in a younger group of men than those that we study. So my perspective about the future is that there needs to be a reorientation of services, exactly as you've said, to meet the needs of men, and men need to be incorporated into the provision of health services. And you raised the point of antenatal care, and I think that is absolutely critical. In fact, reproductive services across the board need to include men as an equal partner in those services, and right through the process of antenatal and postnatal care, men ought to be included. So I think a careful look at the design of general practice, how general practices or how general practitioners communicate with different people in a far more targeted way, rather than assuming that everyone is an undifferentiated patient, are the areas where the biggest advances will be made. Thank you for the opportunity to comment.
And thank you, Gary, for those very thoughtful comments. Dr. Bernales, sorry.
Oh, thank you. Bernales. Thanks for
Bernales.
this opportunity. Yes, thanks for this opportunity to comment this work. I am from Chile, from the Pontificia Universidad Católica de Chile. And one of the reflection of this work is about how we could conducted future research into male-focused health clinics, intending to create a welcoming, more inclusive environment addressing the specific health needs of men. Years ago, I wrote a reflection about the same issue, entitled Men's Health, Modifying Health Strategies or Changing Cultural Roles. On that work, I reflected about how the absence of a clearly demand for healthcare among men and their invisibility at policy level may help explaining why specific health programs for them have been very slow to develop in most parts of the world. Therefore, health workers and healthcare systems are maintaining masculine stereotypes and thus contribute to an undervaluing of the health needs of men. What then should be done to reduce poor health and mortality in men globally? Should health workers adapt strategies to a group of men whilst taking into account how their gender role is linked to macho imperatives? Or should they develop strategies that point to a more profound cultural change, generating spaces where men begin to acknowledge their own health needs and vulnerability? Should it both? Men require health strategies that respond to current needs. The design of health strategies should consider broader social determinants linked to the male gender. At the same time, taking into consideration the fact that healthcare systems importantly contribute to the construction and stability of gender role life, perhaps a long-term effective strategy will be to promote a social and a cultural change. This will need to extend beyond institutional walls, allowing men to show their vulnerabilities and to make use of culturally competent health strategies with an advanced focus on gender issues at the healthcare level. Today, I am working with trans masculinities, and usually trans men do not want to attend health centers due to fear of possible mistreatment and discrimination. If the health system is not sensitive with cis men needs, the situation for trans men is even worse. It is clear that healthcare workers play a central role in the creation of safe spaces that provide competent care for the needs of patients. Respect for gender identity and providing information and psychosocial support are essential to reduce barriers related to the search for support and care. In this context, public health policies focuses on reducing discrimination are fundamental, including all types of masculinities. Thank you.
And thank you, Dr. Bernales. I think I got it right, for that perspective. We have about 5 minutes left. We have a couple of questions in the chat that I'll frame, but then I'll also just ask them together and then quickly ask in the last 5 minutes for all three of you to offer your closing comments. So the first question we have, I'll frame it as more of as a comment, because I think it's really, he's answered his own question. Anthony Brown asked, is there value in reframing how we talk about these issues from saying that men don't understand to reframing it that to put the onus of responsibility on the health services that we are not putting the effort into communicating. So I think I like that reframing, and so I will accept that less as a question and more as just a statement of things that we can actively do going forward. I think John Barry also has a comment that I think mirrors, Gary, what you said, that essentially is suggesting that the overutilization and overfocus on framing things through primarily and only almost exclusively the lens of masculinity is missing a lot of things that I think Margarita, you mentioned, particularly thinking about the roles of social determinants, other things and other factors that are affecting health, that are not being captured by looking simply at or seeing, gender and masculinity as synonymous terms. So I think, yes, this idea of broadening that perspective are two things, in addition to the various things that you mentioned, Ruth, about, the reframing the messages. I was actually going to ask you about the opportunity to think about services available for prevention and so forth, and how to reframe those messages and so forth. So thank you all for the comments and questions. You each literally have about a minute to respond. So I'll go same in order, Ruth and Gary, and then Margarita, and we'll close.
So thank you for the opportunity to present today. Just to say, I look forward to getting the qualitative data and bringing that together, and having, like I said, the voice of the men speak and tell us what they really think about their engagement with general practice. Thank you.
Thank you. Gary? You're muted again.
Interesting comment here about younger men talking to their peers but not talking to health professionals. And I think the reason is that because their peers are receptive. Healthcare professionals are very busy, and guys will not talk to healthcare professionals in terms of volunteering information unless a question is asked. My experience in working with GP colleagues who've tried this is if you show that you have time and you ask the questions, men are just perfectly willing to talk, and you'll have just as much trouble stopping them talking as everybody else. And I think if you take nothing away from this, is to change the pattern of communication from expecting men to volunteer all their problems to asking key questions and creating the opportunity for them to talk. Thank you for the opportunity for me to talk.
Thank you. Margarita.
Yes, thank you. Well, here in Chile, and I think in a lot of parts of the world, gender health is related to women's health. And here, when we start to talking about men's health, usually we are thinking in just a kind of masculinity. So for me, it's very important to be plural masculinities and try to include in the studies the trans masculinities, and as you say, Derek, try to think in the social determinants of health when we are studying the gender issues. Thank you.
Yes, thank you all. And I think the questions, comments that we're seeing are also aligning with that. And just to say thank you all for your participation. Thank you, Ruth, for the wonderful presentation. Thank you, Gary and Margarita, for your comments. This is just to say the work that we're continuing to do in Global Action on Men's Health is to really try to critique, push these boundaries, and to really look at these things anew, to make sure that we question the assumptions that we've made to be able to advance the field to do this work going forward. So we look forward to collaborating with you all in the future. Thank you again for your participation, and we look forward to the next webinar. So thank you so much.
Thank you.
Bye.
Thank you. Bye.